Good morning and welcome to the Western Victorian PHN's Project Echo Hub. This series is about intellectual disability information and education and is part of the SPIDAH Echo Network. So today is Tuesday, the 2nd of August, 2022, and this is our second session in the second series. And we've called this session Intellectual Disability and the Annual Health Assessment. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we're zooming in from today. We recognise their diversity, resilience and ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past, present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination of First Nations people and organisations and will be working together to closing the gap. So intellectual disability affects 450,000 Australians and is recognised that they have poorer health outcomes than the general population. These echo sessions are designed to generate conversation and ideas that we can employ in our practices to achieve better health results for this population and assisting them to access better healthcare. They're organised by the West Vic PHN SPIDAH project team, which is set up in response to the federal government's national roadmap for improving the health of people with intellectual disability, which was launched in July last year. These meetings are fortnightly, and this is our 5th session to date. So far we've discussed the diagnostic pathways of intellectual disability, communication, consent and decision-making, and last week we revisited the important concept of reasonable adjustments. We've been joined by experts in their fields, and today we will have the opportunity to explore the important topic of annual health assessments. So the National Roadmap reports that people with an intellectual disability have poorer health outcomes and are more likely to die earlier from preventable disease, and they're less likely to undertake important health assessments, and often because their carers or themselves have not been given the information in a way they can understand. So the primary health system in Australia is very reactive, so it's often hard for health professionals who are time poor to think about proactive steps we can make to improve the access to health screening for people with an intellectual disability. However, this is the very population where it is important for us to show some leadership in regular health screening opportunities. One of the early goals of the National Roadmap is to support GPs, practice nurses and people with an intellectual disability and their supporters to access and use the Comprehensive Health Assessment Tool, also known as the CHAP tool. And that's what we're here today to discuss. So for those who haven't been to the Echoes before, our number one aim in these sessions is to build a community of practice. And the best way to do this is to be able to see you and to hear you and interact with each other. So I'd just like to introduce some of the Echo team, and we might go around the room and see who's here today. So we've got Whitney and Gemma from the West Vic PHN, and they're helping in the background run the show, and I appreciate their help in setting everything up today. We've got Kerry from the SPIDAH project. I think Kerry's there. Today, we're very pleased to welcome Professor Nick Lennox, who's a Senior Medical Advisor for Disability and Health at the Australian Government. Nick, do you want to just sort of give us a wave so we can know who you are? And we'll introduce Nick a little bit later. With our panel members today to help us discuss this topic, we've got Jane Tracy. Jane's a general practitioner and former director of the Centre for Developmental Disability Health at Monash Health. Jane, do you want to just give us a wave? Our case presentation today will be by Tricia Bulic, who's the Executive Manager of Quality and Practice at Gateway Support Services here in Geelong. Trish, do you want to just give us a wave, let everyone know who you are, and we'll have a chat later. Fraser Lever, who's an acting team leader at Gateway Support Services, will also be involved in the case presentation today. So I wonder if anyone else wanted to introduce themselves today. Don't know who's around there. Adam.
Good morning. I'm the Managing Director at Lancaster Consulting, so I'm going to be running one of these sessions in November, so just hanging out to see how it runs.
Oh, well, hope we do it okay for you, Adam. Welcome and good morning. We've got Tara.
Hi everyone, I'm a speech pathologist at West Women Health Service, so out covering the area to the border from Nil to Kanawa.
Thank you and welcome. And Kevin.
Morning. I'm one of the GPs at the Aboriginal Health Service in Geelong at Wathaurong Aboriginal Co-op.
Thanks, Kevin, and welcome. John's one of our regulars. Hi, John.
G'day, Rob. Everyone, I'm the GP in Geelong West.
Got Denise.
I'm a support coordinator in Northern New South Wales with NDIS.
Oh, hi, welcome. Thank you. A few people haven't got the cameras on there, so if Fiona, did you want to introduce yourself? No. All right. What we might do is welcome everyone to this morning. So we'll just go through our agenda. Probably what I should mention is that during the session today, we will have a didactic talk, which is recorded and available for later on. There'll also be a case study, and that won't be recorded for confidentiality. And I think when we're discussing the cases, I think it's important for us all to remember that confidentiality side of things and respect for that, which I'm sure we all will. So our agenda today, so we've met Nick Lennox. He's the Senior Medical Advisor for Disability Health at the Australian Department of Health. And he's going to do a didactic talk. Then we can about the CHAP tool, and then we can all have the opportunity to ask some questions there. And then we're going to hear a very interesting case from Tricia and Fraser. And hopefully we can all have a discussion about how we can help manage that and some of the issues there that it's going to involve. So just a brief reminder about the cases. Today we've got a slide about case studies. The echoes are all about case studies, and they sort of help us bring to light some of the important information, important things when dealing with people with an intellectual disability. So if anyone has a case study, please feel free to let the Echo team or the SPIDAH team know, and there's a link on the screen there, and hopefully we can come together to sort out some issues people are having. There is some opportunities for professional development. So if we can go to the next slide. So if anyone's needing some points or would like to do that, there's a link there to link on. So we've got learning outcomes for the series. There is a survey. That was a very quick survey if you want to do that. If people can think about doing the survey for us. So learning outcomes from the series has been probably the same through the whole series. Recalling some of the terminology. I think the important one, that understanding some reasonable adjustments down the bottom, and that's been a reoccurring theme through a lot of these talks. And maybe some solutions for the primary healthcare professionals to deliver better quality care for people with an intellectual disability. So really for the session today, it'd be great if we could understand the importance of the annual health assessment, particularly in relation to how it is with the CHAP tool, and having Nick here is a great opportunity for us to do that. And certainly with people with complex intellectual disability and health issues, how we can help them better. So I'd like to introduce a bit formally Professor Nick Lennox. We're very fortunate to have Nick here today. He's been a fantastic contributor to the SPIDAH project. So Nick is a Senior Medical Advisor for Disability and Health with the Australian Government Department of Health. He's a researcher, educator, advocate and clinician, and he has specialised in the health of adults with intellectual disability for 30 years. Nick and his team at the Queensland Centre for Intellectual and Developmental Disability developed the evidence-based CHAP tool to assist primary healthcare improve the health outcomes of people with an intellectual disability. So if there's any questions you want on the CHAP tool, Nick is your man. So I'd like to introduce Nick and thank him very much for coming today, and really looking forward to what your message today about the CHAP tool, Nick. Good morning.
Thank you, Robert. Thank you. I appreciate the introduction, and thank you for everybody coming online. It's as you can hear from the people involved in this group, we're very passionate about trying to get this system to work better. So, and really, just a little bit of the background, I formerly headed the centre at the University of Melbourne between 1992 and 1997, and before that was a GP in various bits of Melbourne, including Footscray and Northcote. And so I have a bit of contextual knowledge around Western Victoria. I was asked to talk about the CHAP tool, and I'll talk about that. But firstly, you must be absolutely aware that I have a major conflict of interest, because I was the chief person that drove this from about, really actually work started about 1995 through to 2020. The University of Queensland decided that there was intellectual property in this tool once I'd proved that it worked, and we got a Medicare item generated from the tool, and therefore they licensed the tool to state governments. And as the inventor, I receive a third of the income from the CHAP tool. So I have a major conflict of interest, and also with the health department now, because the health department is trying to acquire it, a process I'm absolutely kept out of. Anyway, it has been a journey of somewhat, and the reason I went down this journey is because I wasn't that interested in research when I was at the University of Melbourne, and I thought, if I'm going to do research, I want to do something that works, and looked at what was available. We did some testing in general practice, and thought the thing that had the most impact was a health assessment driven by people with disabilities, but done by GPs, and that's why we went down that path, and that's on the back of the fact but we know that there's lots of missed and poorly managed health conditions in the population. Health promotion, disease prevention doesn't happen, and often there's a whole lot of problems in access to primary healthcare. I'm an absolute fan of general practice and the primary healthcare system. It is the best system in the world, and Australia is one of the best. Even though there's lots of problems, it's better here than virtually every other country in the world. So I wanted to work in that general practice space. I was asked to talk particularly about the key principles, and I was asked to minimise the PowerPoint slides I used. So, and realising that with PowerPoint, there's so much power and so little point, I decided not to do any PowerPoint slides. And I thought about talking about the key principles. And the key principles are embedded in the CHAP tool, and I've actually got it here. I can flick it up if people want it, but is to try to minimise the multiple barriers to primary healthcare delivery. So what it does, it tries to get access to general practice, and so that the GP is actually seeing people and not focusing on the presenting complaints, not presenting, because people come to us, and I've never had a patient say to me, when I say, what brought you along? They say, nothing, I'm quite well. I've never had that happen in general practice. So it was an idea to actually get to focus on things other than what's going on. And in general practice, we often use this anyway. We bring people back and get another look at them. And that's one of the big powers of general practice. So it's about access. It's about gathering the story. And Jane and I and everybody that works in this field know that people's health stories disappears. And I've got some terrifying stories of people's life stories disappearing. During the process of the health assessment research internationally, some families were reconnected as a consequence of gathering that story. The services had lost contact with the person's family. That's how powerful it is. So it gathers this story, and it's reliant on people with intellectual disabilities, their carers, and support people, be that families or whoever, to gather that story. So it's trying to get that decent story. And too often we don't get a decent story. And if you don't have a clear health story in health generally, in fact, in life generally, then you really can miss out. So it's doing that process. It's also trying to empower carers and GPs and people with intellectual disability by providing information about health at the time when they need it. And the idea is really two. It's one, so that the carers and the family and the person with disability enters that process knowing that these are the things that are commonly missed. And I've seen this happen live when we were piloting the CHAP tool. So I took it to a search service, and the carer looked through it and checked it for face validity of the first part of it, it's called, fancy word. And then said to me, he went through and thought about the other person they were supporting, and I'm sure Fraser and other people in Tricia's service would do the same thing, and they went, oh, wait a minute, Tom might have this, because I've got a list in there of things that are commonly missed. Oh, we better check this with Brian, etc. So it's actually empowering the advocates to go into the general practice and say to the GP, what about this, and what about this, and what about this? At the same time, knowing fully they've got a university validated tool that says these things are real. And that's quite powerful, because carers are often disempowered in systems. as is people with disability and families indeed, Jane. And it also educates GPs, because the GPs are just set upon in the current healthcare system, and they need all the support they can get, actually. And so it says to them, these are things you really should look out for, and prompts them to look for it. And provides a little bit of information on things that you're just not going to know as a GP, like about, you know, if somebody's cause of the disability is unknown and hasn't been thought about for 20 years, what you should do. You know, there's assumptions made, but that's not a problem. So it prompts the GPs and focuses them on things in the report, and some of those things occur in the case that we will discuss. It also forces people to sign off, carers to sign off and say, I will come back and I will do this. And we will come back and see you as a GP, because one of the things that falls apart in general practice is people don't come back, which I mentioned. And it's crucial. And in fact, it's one of the biggest powers of general practice, is that ongoing bond you have with the patient, and that you can then pull them back in and go, okay, what about this? What about this? Let's do this today, do this next week, do this. And you can do that if you can get cooperation and facilitation and mutual respect and make it work for you. And also, I think doing a health assessment process and then going to a chronic disease management plan helps you do that. It has some added extra information in it about syndrome associated conditions, and GPs love this when we trialled it. And the reason they loved it is because it empowers them. It's in the words of their profession. It has, you know, things like rhabdomyosarcoma, which makes us feel good and warm because we know what it means and nobody else does, and things like that. So it's you know, I don't know how effective, but it makes GPs feel good, and it has on the back of the thing a mirror chart for testing people's eyes. So it has those kinds of extras to it. When using a tool like the CHAP, I think there is the key thing that people don't get is this is actually a tool that's driven by people with intellectual disabilities, their families and carers. It's not driven by the GPs. We piloted through driving it through GPs, did not work. And we got clear evidence that if you rely on that close relationship between the person and the people that care for them, that drives the research. We got 70% of people with disabilities agreeing to be involved in this research and their families, because they knew that it was worth doing. And when we rang their GPs and we said, your patient, note your patient wants to be part of this, we got 90% of GPs involved in this. Is because the GP's got a relationship with that person, and that connection is absolutely crucial. And you break that connection and it will cost the person if you break that connection. You need to make it work as best you can. In fact, so much so that I've presented this internationally, because it's about love, it's about connection. And I've presented this nationally, internationally, as love in the time of randomized controlled trials, because it's actually about connection and love. Got them to smile too. A lot of the CHAP can be done by a nurse, virtually all of it, and pulling in the GP and getting in and doing the GP diagnostic bits around it. And I worked in New Zealand and other places with practice nurses, and some of them I would kneel at their feet and thank them for working with me, because it was such a good experience. So if the practice has got that, and that can make it more economic as well. As I said, you can go to do a chronic disease management plan. I think also this is not only a tool for GP, it's also it is broadly a communication and advocacy process. And it's some services, and not the services we're talking about today, are not following up and not doing the work. And I think it's an opportunity for GPs to make sure they're being honest, the service is doing their job. The tragic death of Anne-Marie Smith in Adelaide last year, had she had a health assessment, which she didn't have, then maybe that would not have happened, and that GP would have said, this is just not good enough, you need to do something. In fact, the report on her death recommends implementation of annual health assessments. So it can have a whole lot of different things. Now, the bad news about the CHAP is that the Commonwealth Government's still negotiating with the university, so it's not as accessible as it should be. The vision for the Commonwealth Government is to integrate this as easily as possible into general practices. And I will be pushing to make that happen as much as I can, because we really, really need to support people with disabilities, their families, their carers, and also their GPs. to do a good job. Thanks, Robert. That's me.
Look, thanks, Nick. I think I would assume that a lot of the GPs in the audience here have used the chat tool. I'd love to hear anyone's comments or thoughts. If anyone had any questions they'd like to ask Nick, or comments about the chat tool and their experience. Anyone wanted to?
In forcing Rob, I've had basically no exposure to it. I think I've seen the letters float past and things, but I've really had no exposure in a long career in general practice. So it's really embarrassing.
I don't think it's that embarrassing, to be honest. I think it's the implementation was done very poorly by the federal government after we got a Medicare item, and that's what we're trying to correct.
So my experience, Nick, is that the patients would often come who are in a care situation or have an organisation who are looking after them, and it's brought to me because there's a requirement in that organisation to do an annual health assessment. They need to tick that off as a requirement for something. And they may be brought by a staff member who may not be that familiar or has not invested in the chat tool as something, oh, we've done all this and I can't really see the importance of it. So I suppose my experience is I don't get a very positive approach. And so it's nice to hear from you the evidence base of it, and that maybe as general practitioners, we should be a bit more proactive and saying, great, that's the chat tool. That's a really important part of something we need to do, and to almost empower that carer as well to say it is an important part. And because I think if they come to their GP and the GP rolls their eyes and says, I've never done one of these before, and what, just more paperwork, it loses some of its power as well. But it'd be nice to embrace the chat tool, or just, not even call it the chat tool, but it's the annual health assessment, isn't it? It doesn't have to be the chat tool, because really the chat tool can only be done when someone brings it to us and it's licensed and they've paid for it. But you can do an annual health assessment as a GP as well, can't we?
You can. I mean, the Medicare item clearly says an annual health assessment at the moment. They're currently reviewing, to be honest. I would argue that you need multiple components, that if some of the checks that are put out there are really GP-driven checks and not gathering the other bits of it around it. And, you know, it's no doubt, you know, we had about 5% of GPs, was about 5% who just felt it was another bit of bureaucracy. And also, if you select people into a trial, they're people who are putting their hand up and say yes, which is, so it's different than the experience that you've had. In Victoria, in fact, there was a woman called Helen Matters who drove it, the implementation massively in Victoria. And I think it's, part of your experience, I think, speaks to me the fact that organisations need to get on board on this and understand that they actually do have a responsibility to be across the health stuff. So I'd say that's a failure of the disability organisations more than anything. It's also true, you know, for some people, you could do a complete health review and they're fine. But it's just unlikely that you're not going to find anything. The last morning thing I did was to a general practice near me in Ipswich, and we had a GP there who was also a father and a brilliant practice. And he looked at me at like early in the morning. He said, "Nick, I thought this was a waste of bloody time," and which GPs are apt to say. And because he had, you know, had a daughter, and he said, then I kept doing it, and I kept finding things. And I thought, yeah, that's right. You know, that's what we do. Not just the chat, but if you go over somebody in detail, then there's going to be, they're often, we would say, trivial things like blocked up ears or skin infections or things that are not that important, but completely missed. That was one of the things, in fact, that was really dominant in some of the findings we found. The other thing, Robert, I think also was used in the deinstitutionalisation of the last institution in Tasmania. There's a small paper. And what it did is it allowed difficult, like the case we've got today is incredibly complex. And these people were coming out of institutions to a new practice, and it allowed some time for the patient to spend with the GP and for the patient and vice versa. And there was a build-up of trust because they had some time that they could negotiate around and get a feel for each other. And that was quite evident. So I think that can be that advantage. Anyway, I'm talking too much, Robert. Has anybody got any questions?
Can I just ask Nick and Rob, so tell me again, the access to the tool, is it actually not available or limited or?
It's available through license, unfortunately, through the University of Queensland to organisations. You know, if you want one, I'll send it to you, John. Just email me.
So at this point, as Rob said, is someone coming to us actually with this document? Is it sort of how it actually works at the minute? That's how it works. Is trying to pull the systems together in a very active process, because, as you know, they almost they're quite separate and they don't integrate very well. So it's trying to get disability and health to actually play together in the same. So, but it has to be driven by people with disabilities and their families. It was very clear from the work we did.
Jane, did you? Yeah.
Organisations like Scope and Urella and Able incorporate them into the way that they care for people in supported accommodation, so that it comes automatically then through them. But they don't understand often that it's a part of the process. It's not the full process. It's a gathering. It's an information gathering tool, and then it requires the focus from the nurse and the GP to identify the issues that the tool has raised and address those issues. But it certainly provides a focus on not just acute health issues, but those chronic issues that have been overlooked, or those issues around preventive health that are often missed when people attend general practice.
So there is an item number, isn't there? For a long consultation for an annual assessment for someone with an intellectual. Is it 707 or?
I think
the Medicare describer has a list of requirements for that. It doesn't necessarily have to be the CHAP tool, but I suppose if in general practice you were initiating an annual health assessment, that may be a good starting spot, because there'll be a lot of patients who aren't in care. You know, my son's not in any organisation that would use a CHAP tool, but it would lovely to, if he came for an annual health assessment, to have a tool which the GP can follow, and it sort of pays reasonably well with Medicare. It's not an insignificant item number to use. I'm surprised more people haven't cottoned onto it to get, and it's an opportunity to get people back and to say, this is what we do and this is how we engage you, and you know, you're not going to present often by yourself with a health screening or preventative health stuff. So this is an opportunity to sort of engage with you and to get remunerated.
It's exactly the same as the complexity with older Australians, isn't it? The benefit of the health assessment item that's used widely for them, but not widely for people with intellectual disability, but the principles are the same.
Yeah. Did anyone have any other questions? Kevin? Kevin Chang.
It's been a while since I've worked in a mainstream practice, so that was probably the last time I filled out the CHAP tool. Was literally, I can count it on one hand. But since moving into the Aboriginal health space, I found that people that have intellectual disabilities are just getting an Aboriginal health assessment, and I just wonder, if there's probably a lot of overlap, but at the same time, I'm sure there's also bits that are included in the CHAP tool that are not in your standard Aboriginal health assessment. And I wonder what those are.
I can confidently say I don't know the differences. I haven't lined them up, Kevin, I'm sorry. The irony is that there is a specific item for Aboriginal health, but not one for intellectual disability, from my point of view, even though, in fact, so I don't know the differences. There presumably would be differences, and I think it's going to be, they're currently, MBS is reviewing the evidence around assessment items, around health assessments. And so I think there'll be some further work to decide what you will be able to use at looking at the evidence. In fact, Paul Glazier is looking at the evidence now. So I can't answer that question, sorry, keep going.
I think one of the important things with the CHAP tool, Nick, is it does involve the carers as well, doesn't it, to go through those things?
Well, it's
which
totally
is different
crucial.
to other things, yeah.
Yeah, look, it's totally crucial, and people completely forget about it in the medical centre. But if you practice in this area for very long, you realise people's health stories just disappear unless you force people to actually collect them. You really are. I've examined somebody in Western Victoria at Footscray once, and noted that she'd had a hysterectomy scar and said to the staff she's had a hysterectomy, and they turned to me and said, "Oh, that's why we can't get a pap smear." She didn't have a uterus to pap. And it's those type of things that really shouldn't happen because of loss of history. So it's really crucial to get that. Yeah.
All right. Thank you, Nick. Is there any other questions for Nick before because I'd love to move on to the case study, because time's always against us in these sessions. Just remember the health pathways here as a way for GPs to get some information on intellectual disability, and that's been increased all the time. I'd like to just acknowledge the SPIDAH project and the help of Kerry and Nicole throughout this process. There we go. There's the SPIDAH slide there. There's an evaluation of these echo. Oh, there's the case submission. So if anyone else has got a case they'd like to have a chat about, I'd just like to remind people of the next SPIDAH echo in a fortnight's time on the 16th of August, and it's at 7:30, and it's going to be entitled The First 2,000 Days of Life, where we'll be discussing the critical time for physical, cognitive, social and emotional development. And our presenters will be Catherine Maffra, the Deputy Director of Neurodevelopmental and Disability at the Royal Children's, our very own Dr. Bernie Jenner, who's a consultant paediatrician here in Geelong, Dr. Bill Gavney, who's a paediatrician at the Royal Children's, and of course Jane Tracy will be joining us again. So I'd like to thank everyone today for attending. I'd really like to thank our expert panel who have joined us to help us understand the very importance of being proactive with regular health assessments. So big thanks to Nick for joining us from Queensland. Thank you very much, Nick. It's been a pleasure having you here, and the important work of the annual health assessment and the CHAP tool. And I hope we all understand it a little bit more and can find ways to incorporate it into our practice, or at least that annual health assessment. And thanks to Tricia and Fraser for their time as well, bringing this complex case for us to discuss. And of course, Jane, thank you very much for your contribution as always. So I'd like to wish everyone a great day and look forward to joining you in a fortnight. So thank you very much, everyone.
All right.
Thanks.
All right.
Thanks, everyone.